So what I'm here to do is to talk to you about consumers and accreditation, particularly in respect to pathology testing, and really rather than what we know, what we need to know. And it's been a theme of right from the very first keynote that the public needs to be more aware of accreditation and how it happens within Australia. And the accreditation of labs was particularly put to the test with the COVID pandemic and showed that, yes, pathology testing in Australia is safe. And I've just given my declarations of interest. I'm a pretty average consumer representative or advocate. I am the chair of the RCPA Community Advisory Committee, so know a little bit more about pathology than the average consumer. But I'm not paid by the college and I have no industry affiliations. So the role of pathology, what we know. We know that pathology is a highly technical medical speciality, and it's made up of a huge team: pathologists, medical scientists, laboratory and information technicians, collection staff and others, all working together. And in this way, it's actually pretty unique in the health system, because it's a self-contained, highly effective team. Some 70% of all healthcare decisions are made based on pathology results, 100% if it's an oncology situation. Yeah, and pathology is lab-based. It's not subjective providing care. It's actually providing results. And these results are important to make diagnosis of disease, to monitor treatment, and is all provided by well-conducted, accredited pathology tests. And the accuracy of these tests is really important to us. Our blood sugar levels can change by a couple of units, and suddenly we're given the label of being diabetic. So this matters. The accuracy of the results really matters. We are very lucky in Australia. The bulk of the pathology services, not all with the advances in technology, but the bulk are covered by Medicare. And in order for these tests to be Medicare funded, they need to be accredited. So the pathology laboratories receive funding through Medicare for providing these tests. But again, it's another unique situation. It's not all tests because the testing is capped. And so pathology labs actually do far more than they're paid for, hence the awareness for funding. We as consumers are expected to manage our own healthcare. We spend very little of the time on average in the presence of healthcare providers. We have to follow treatment plans, take our medications, change our lifestyles, and also at the same time become aware of signs and symptoms of disease and side effects of treatment, and so know when something's wrong and that we need help. We also know what support we have around us, where the value is for us, and our obstacles to care. And we're working within a person-centred healthcare system, or we're heading toward that way within our healthcare system, and shared decision-making. So even the provision of how we get our pathology results is changing with the digital age. And we now have the My Health Record and the electronic medical records and patient portals within hospitals. Another thing about pathology is that it's not just a hospital service, it's part of our community. So pathology services covers the whole gambit of our lifestyle. And wherever we are, regional and remote, as well as in cities. And as I've said before, it's well funded, so most of us can access pathology testing. What we can be grateful for, we need and actually have access to pathology results that are timely and accurate. And we expect person-centred care. And we need to be informed by our pathology results to be part of effective consultations to that precious time that we do have with our healthcare providers. And pathology testing has proven itself. COVID-19 pandemic gave that to us. It showed us that pathology results can really be trusted, and it's really important. But the other thing is that we just take it for granted. And yet the pathology system just keeps on giving, and we keep on taking. We need far more awareness of what is behind that quality pathology service that's available to us. We're very lucky in Australia, as Laurie pointed out, and Andy has given some really great examples, that we have a well-accredited pathology system in Australia. And that's really important. And it's backed by legislation and strong regulation and support from the Department of Health and Aged Care and funding through Medicare. That's all important. And NATA has worked really closely with the college over the last 40-odd years to make this happen. And so we're, in a sense, we're very safe and secure in Australia with our pathology services, and we automatically rely on them. And often where the breakdown in the system is between the referrer and getting the results back from our pathology tests. Because pathology has been very much part of a service to the referrer to provide pathology tests. So what we're saying now, it's now time for pathology to start looking at the consumer and embracing the consumer into that delivery. And with all the digital technologies, that's becoming more and more possible. And so we need to think more about the reporting, not just to referrers, but also to the consumers themselves. So change, but pathology is very used to change because technologies are developing at an incredible rate, and pathology testing has had to move along with that change. So we as consumer advocates, we often work within a hospital environment as well and are involved in hospital accreditation. We try to give work as consumer representatives in those hospitals. We're aware of the communication issues and the hierarchies of the different staff, which makes it a very different environment to the teamwork of the pathology labs themselves. And we have problems in hospitals as well at an organisational level. So from the staff themselves to management, the lower management to upper management, and actually in a sense, getting the ear of the senior executive to what is important to the safety and quality of healthcare. And hospitals tend to, they all measure KPIs, but when you can't change your KPI or it goes along zigzagging, what do? Benchmark against other hospitals rather than trying to really change that system itself. And all right, we have standard 2, but consumers have to wait to be invited in to be part of that hospital system. And also, we're well managed, that we have coordinators who look after us within those environments. So we're only present in pockets of the healthcare system. So there's a lot that the health hospital accreditation still has to do. And it also, I would argue, when was it last assessed? And I think a number of us as consumer advocates within hospitals work with sentinel events and root cause analyses, and we come up with cases where pathology is implicated in a sentinel event, but it is not the result that is in question. It's whether the referrer or the doctor in charge of the patient has read or even taken notice of that pathology result. And that still continues with the electronic medical record. So my role is to impress on you that we need to maintain that public trust in our pathology workforce and the pathology services and the system of accreditation. And that we need to maintain trust in the timely access to accurate test results as and when they're needed. We need appropriate tests, we need accurate results, and these need to form part of effective communication and consultation in healthcare. So there are themes: legislation and regulation, employer practices, technical standards, technical advancements we're all taking advantage of. For example, the COVID test being a DNA test. We need to go on. We need to consider not just the funding of pathology tests and all the newer tests that can help us, but we need to improve public awareness of the importance of accreditation in pathology services. And this can benefit the workforce because it improves consumer access to care, experience of care and health outcomes, improves safety and quality of healthcare, not just in hospitals but also in communities, and increases public trust. And this one I'm going to flick over quickly, but it's more a summary of what I've been talking about. So what do we want? We want and have reliable, accurate and timely pathology results in Australia, wherever we are. The COVID pandemic has taught us that, yes, pathology can be adaptable and meet the situation and still provide us with timely, accurate test results. It has also taught us that there's a lot of issues with self-testing and, for example, and some point-of-care testing as controlled by the TGA. And we want more transparency about this. We want the public to be better informed. And guess what? The benefits for the consumers are the same benefits as they are for the workforce. So in summary, in Australia, the quality of pathology is taken for granted and it just keeps on giving. So let's celebrate that, but we want it to continue in the same trusted way. We know there are problems with the accreditation system. Supervision of laboratories been a difficult issue, but they're all part of that trust. And if we were to change the standards and the way pathology is accredited, I think this would be a very dangerous experiment. And on what basis? What is the evidence? Why would we change something that's been working well for 40 years? And also pathology, with its rapid advances in biotechnology, can be part of that the world of biotechnology, and can contribute to advances in science of disease worldwide. So I want to thank you. Thanks.
Thank you very much for having me, and it's a pleasure to join you here in Sydney, where I spent the first 4 years of my paramedic career, so it's always nice to come back here and speak to you today. So I'm a paramedic, a clinical paramedic and researcher with Monash and Ambulance Victoria, and I represent Ambulance Victoria in the conversation here today. So the environment that we operate in as flight paramedics in particular, we call a VUCA environment, or refer to it as a volatile, uncertain, complex and ambiguous environment, and specifically a complex adaptive system where we see a lot of interconnected components, spontaneous reorganisation of the systems, learning and evolution of systems, and that there is reliance on all of these interactions, and a single lever at any point in that system can lead to failure. All things and concepts you're very familiar with. The environment we refer to with regards to the teams that we work amongst are mission critical teams, in that they are small integrated groups of people trained and educated as experts. We'll see that level in a second, but we leverage tools and technology to resolve complex adaptive problems within the VUCA environment that I referred to. We have these immersive environments, and the consequences of getting things wrong are death to either the patient we're there to serve, or unfortunately in some circumstances, given our environment, the practitioners or the operating aircrew in particular, and unfortunately that is not unprecedented in our region. So the organisation where we work has a whole bunch of accreditation standards, certifications that need to be met to make sure that we honour the charter of delivering care to the community. And in particular, the two major groups that we work with in my environment are Ambulance Victoria, the sub-department of that, Air Ambulance Victoria, and Babcock Mission Critical Systems, who are our aviation contractor. So in this environment, Ambulance Victoria asks Babcock to deliver the aircraft itself, the pilot and the aircrew officer. We work as a team of 3, and the paramedic is an Ambulance Victoria intensive care flight paramedic, usually with more than 10 or 15 years of experience commencing in that role. So really, I'm going to show you what it takes to be certified to even roll out the front door, which we'll get to at the end. So for Ambulance Victoria, it needs to be a registered training organisation to ensure we deliver the training to our staff. And similarly, ISO standards, I saw Joni's great reference to the pyramids being complicated by their ISO certification, which we're about to go through again. And also we will accredit to the NSQHS standards later in the year as well. And Babcock themselves need to have an air operator's certificate with CASA to be licensed to deliver aviation services. When we speak to the aircrew specifically, our pilots have a minimum of 2,500 hours experience, which may not sound like a lot, but that's about 10 years flying before they come to us, because they need to have a range of certifications, such as an airline transport pilot's license, an instrument rating to fly in bad weather. They have to be rated to the type of helicopter that we have, the AW139. They have to have night vision rating, a whole bunch of other qualifications and prior experience. The paramedic, and Sarah has pictured there, our first female microflight paramedic at Ambulance Victoria, who's been with us for about 6 or 7 years now, has to have a Bachelor of Paramedic Science. She has to be registered with AHPRA. She has to have a further graduate certificate in being a MICA, or intensive care paramedic, further graduate qualifications in aeromedical rescue and retrieval, 10 years experience, 5 years as an intensive care paramedic, fitness requirements, an authority to practice and currency to perform winch rescue, and our aircrew officer, Trevor there, 500 hours in that role before they can even start with our organisation. For the paramedics themselves, we spend a very substantial part of our time preparing for these inevitable outcomes, which involve complex patient care environments. So we need to be recertified and accredited in pre-hospital emergency anaesthesia every year, and specifically around the at-risk groups such as paediatric or elderly patients in our community which have their own discrete needs. We have to meet a mandatory practice skill set minimum requirement of 26 individual accreditations per year, and we spend a bit of time in hospital working with senior medical staff to oversee and accredit our practice. For our surgical skill set, we have to, again, be overseen by medical professionals in regards to some of the advanced skills that we perform for our patients who are critically unwell. This type of helicopter needs to be certified in its own right through the European Standards of Aviation before it can roll off its production line. This is the most modern search and rescue helicopter manufactured today, and we're fortunate in Victoria to have 6 of them, and have about 15 of them here in New South Wales. So this is the universal standard of helicopter for aeromedical rescue and retrieval. The aircraft engineering and maintenance standards, which if anyone's ever been around helicopters, there's no other way to put it, they are a pain in the bum. They require way more maintenance than they do flying time. They have scheduled maintenance time offline every week, and so we rotate that around the state so that it's never all of them offline at once, of course, but they have a very high, something around about 1 hour maintenance for every 10 to 12 hours flying, roughly. So you don't get away with much flying before it's back in the shed, shall we say. And the specific type of service that we offer above and beyond a road ambulance, for example, may be our hoist or winch rescue, and that is one of the most risky procedures that we perform, and the hoist on the side of the helicopter itself requires its own certification. And when you'll shortly see the size of that cable, and you'll understand why it would need to be very closely inspected regularly. More to the point here, we've recently undergone a evolution in our carriage of blood components on our helicopters. So for more than a decade, we've carried 4 units of O-negative patch red blood cells, and that is very closely scrutinised, and we proudly have the lowest proportional wastage rate in the entire Victorian health system because we are so stringently observed in our ability to minimise wastage. We've recently undertaken a number of research projects around delivery of alternative blood component therapies such as freeze-dried plasma, which is not technically used in Australia very commonly, but we recently completed a small randomised trial of its use, which shows some promise, understanding the complexities of using a frozen product and trying to thaw it on the way to a job or whatever, or get it out of a lab. So all of this needs to be accredited to the appropriate standards, the cold chain, the tracking of temperature, and the fridges back at each of the bases. So we have an Arrowsmith and Grant 200-litre fridge at each base where we maintain the cold chain, and then we have local arrangements with each of our pathology suppliers. And recently, we've gone through the process of complying with blood management standard for NSQHS, which has been one of my major projects this last 18 months or so. All of the gear that we use, including our medications, our restricted medications, need to meet NSQHS medication safety standard, and all of our gear needs to have biomedical engineering compliance via our contractor, Chemtronics, in Victoria. Each piece of our medical equipment we would use for an individual patient encounter, so the cardiac monitor and defibrillator, the ventilator, the syringe drivers, all need to have their biomedical engineering checks. They all need to be safely mounted in the aircraft to meet the standard of crashworthiness. Our seat needs to meet the crashworthy standard, and unfortunately that accreditation process makes that the single most uncomfortable seat in all of Australia. So it's not comfortable, but if we crash, it'll collapse and I will hopefully survive. So the stretcher base itself has to go through CASA subpart 21M accreditation to make sure that it stays on the floor in the event of a crash and that it meets the needs. The safety harness that we use for our winch and hoist rescue needs to meet an ATSO standard. All of our training and accreditation for night vision training operations, for example, so night vision systems use is historically been confined to military operations, but over the last decade it's moved out into civilian search and rescue operations so we can provide a 24-hour service. And so all of the interior of the helicopter has to be compliant for those green light operations, including the goggles themselves, the interior compartment, and the pilots and the aircrew officers need to be specifically accredited to operate in that environment using that technology. And they are incredibly high risk procedures. For example, doing remote area night vision goggle guided dark confined winch rescue, for example, is one of our highest risk procedures, but we do train to that standard. Within the aircraft itself, a couple of our search and rescue pieces of equipment need to be accredited. Of course, the entire radio suite, we need to be able to communicate across both the metropolitan and regional areas with all emergency services and the other paramedics that are operating at a case. We have a winch rescue basket that you'll see in a second that needs to be accredited to CASA standards. We need to have our ultrasound that we use accredited, and we need the individual clinicians who operate it to undertake the appropriate accreditation for ultrasound scanning, which we use to look for chest injuries and bleeding, etc. We use Abbott iStat for our blood chemical analysis, usually in flight on the way back to hospital to understand blood chemical changes. And so point of care testing is a big part of our operation, and we're recently pushed into some other areas around other biomarkers for our very unwell major trauma patients in particular. So when you look at our complex operations, you'll see that any single point of failure can have catastrophic consequences, and why in the middle of Bass Strait we need to know that every person, piece of equipment and system is accredited or meets a standard. And it also involves comprehensive training to that standard, where we spend a great deal of time training to make sure that we can deliver that service. Similarly, this is a case of a winch rescue that I undertook out the back of Falls Creek a number of years ago. We need to be able to go to the ocean 1 minute and then up to the snowfields the next, or into some other remote area. And so we spend a full 2 days training at Mount Buller in snow operations each year. Every paramedic working in the aircraft environment needs to meet a minimum fitness standard, and we have mandated that standard through deep investigation into the physiological requirements of the role our staff are required to undertake. And that includes, for any of the physiologists in the room, you would have seen a Douglas bag from back in the day there. But my entire PhD was around establishing the fitness and physiological standards for our staff to make sure that we don't include people who can't do the job and provide the service, but importantly, we do identify the people who've got the capacity, and if they don't, it's our obligation to help them meet the standard and empower them to be the person who can do that job. So we spend a lot of time making sure everything is quantified to ensure that they can meet that standard. And we look at a typical case and the points of this VUCA environment or complex adaptive system where failure might occur. Cases come from our 000 call centre in Victoria to this base. This is our Essendon Airport base where we house 2 of the helicopters, and this is our flight coordination desk, and they'll triage the case as appropriate. My personal work location is at the Latrobe Valley, about 150 kilometres to the east of Victoria, where our single helicopter base would receive a call and we'd be sent out to depart from that base pretty much to anywhere in eastern Victoria or eastern or northeast Victoria, or even to the south into Bass Strait. We're the closest helicopter to the north coast of Tasmania as well, and we can often beat the Hobart helicopter to the north coast of Tasmania. When we respond to the case, we need to obviously start up and head out, and we need to consider all the weather. That's one of the very rare days of a blue sky in the Latrobe Valley. So we take them as they come, but often there'll be complex weather systems involved right at the foot of Mount Baw where we're located, where there's those sub-mountainous environments. And then we might be required to head out to a remote location, and we might be able to land in that environment. In this particular case, it would involve, you see that cable, it's not particularly thick, and you can see that that's about 250 foot off the ground, and there's a lot of time involved of the helicopter being involved in a hover with somebody as an external load being winched onto the ground. When we get there, we want to work with accredited rescue agencies who will help us looking after the patient, making sure all of my equipment is working, reliable, and I know that whatever value I see come back, blood pressure, blood lactate, hemoglobin, whatever value I'm measuring, I need to know is reliable to make a decision. And I'm making a clinical decision not in isolation. I'm making that clinical decision in that complex of adaptive system. How am I getting back to Melbourne? Is the helicopter working? Is the pilot fatigued? Are we safe to get out of here? Do I need to winch the patient out in a stretcher? Now, in that case, no, but sometimes we do need to winch the patient out in a stretcher. And again, I need to know that all of the systems are dependable, right from my harness to the harness that's securing the patient in the stretcher and all of the other bits and pieces that go with it. On the way back to hospital, the current environment we work with is one where it's a single clinician in the back. The aircrew officer can sit in the back with me, and they are trained to a high medical assistant standard to be able to do things like take a blood sample. I can give them a blood sample, and they can use the iStat to generate the sample. They can help me switch the buttons on the ventilators and the cardiac monitor. But largely, the single clinician in the back is a decision maker who's trying to manage, in this case, a critically unwell patient with multiple blood units, disturbed physiology, multiple drug infusions. I simply don't have the bandwidth for any of those pieces of equipment to not be reliable. So they must be accredited sufficiently. Otherwise, I'm making decisions on poor information. And then finally, we get back to the hospital, and the one thing that we do want to know is that the helipad is certified to an accredited standard so that we don't go crashing through to the bottom floor of the helicopter. So of course, at the end of the journey, accreditation still very much matters, and it matters because we're here landing on the top of the Royal Melbourne Hospital. So accreditation matters very much to us. It may not seem like it a lot of the time, but the dependability of systems and equipment function in particular, we are a very, very highly dependent equipment workforce. I can have all the great clinical ideas I like, and my wife often says to me, you could help in a situation. We're no good without the tools, and we're no good without reliable tools. So accreditation does matter, and standards matter to us, and I'll finish with a slight anecdote. Early in my paramedic career, actually in Sydney, had a good mate who worked as a assembly line supervisor, if you like, for Nestle. I can't specify the exact role that he did, but he managed people making ice creams. And he used to gush about how important it was to be a paramedic and how his staff were just, clocking on, clocking off, doing their job. And I said, yeah, but they matter, mate, because I want an ice cream. So everyone in a role matters. It doesn't matter what you do, but ultimately you're all serving a greater purpose, and we really appreciate it. So you do matter a lot, just as much as an ice cream, but more probably. And I thank you for your time, and it's been a pleasure to come here and speak to you.